is ominous that so many TB patients are moving around and spreading infection to others. So we have to be more vigilant over the next few years, report more cases, diagnose more cases, and treat more cases. I would like to discuss briefly about abdominal tuberculosis, because this is one condition, this is one form of tuberculosis which is very difficult to diagnose, often misdiagnosed, often overdiagnosed, often underdiagnosed. So it's quite tricky situation often that we encounter. Now, abdominal TB is usually intestinal TB. Half of the abdominal TB are intestinal TB. They may be small bowel or large bowel, though the upper GI TB is quite uncommon. Gone are those days when children used to consume raw milk. Then oral TB, tonsillar TB was still prevalent, but nowadays upper GI TB is not that common. It's more of small bowel and large bowel tuberculosis. It may be ulcerative, it may be ulcero-hyperplastic or hyperplastic, and often there is overlap also. Sometimes the TB is nodal. The reported incidence varies from about 4 to 40%. Other form may be peritoneal, which is also approximately 1/4 to half of the cases of abdominal TB. The peritoneal TB may be of two types. One is the dry type, one is the ascitic form. And then there are chances of visceral TB like hepatospleno, sometimes pancreatic, disseminated, but this is relatively rare. What is important is involving more than one site, like the gastrointestinal tract, lymph node, peritoneum, and there may be overlapping presentation and varied presentation. So an intestinal TB might be associated with a peritoneal TB or a visceral TB and a nodal TB also. So we have to be very, very vigilant. Now, the clinical presentation may include some obstructive features, sometimes a lump, sometimes an abdominal distension due to ascites or organomegaly. There was some data from SGPGI which showed the commonest symptoms of abdominal TB were anorexia, weight loss, abdominal distension, fever, and abdominal pain. And in the signs, half of the patients either presented with ascites or hepatomegaly. The other signs like lymphadenopathy, splenomegaly, edema, chest findings, lymph node mass, or icterus was still lower. As far as symptom is concerned, constipation, diarrhea are sometimes present, but it's usually an abdominal distension and sometimes a lump. And patient may or may not have the associated systemic presentations, as I was telling, like the anorexia, weight loss, or fever. So the characteristic features of pulmonary TB or lymph node TB, like the anorexia, weight loss, or fever, might not be present in abdominal TB. That's why abdominal TB is often very difficult to diagnose. As we know, it's a Pandora's box. The abdomen is a Pandora's box, and it's often very misleading, and so many systems can overlap. Now, pathogenesis of abdominal TB, the most common is the hematogenous spread from an active pulmonary or miliary tuberculosis. This signifies that if we suspect an abdominal tuberculosis, we definitely should try to rule out pulmonary tuberculosis by chest X-ray and CBNAT from sputum or gastric lavage. So it's usually a hematogenous spread from an active pulmonary or sometimes a miliary tuberculosis. As part of miliary tuberculosis, the GI system is also involved. Then there may be ingestion of contaminated milk, which is not that common nowadays, but still, yes, it is a possibility. And of course, the other pathogenic mechanism is the swallowing of infected sputum in patients with active pulmonary tuberculosis. The children, they usually do not expectorate, they usually swallow. So hematogenous spread and swallowing of infected sputum are the commonest. The tubercle bacilli enter the gut. They traverse the mucosa, usually through the Peyer's patches and also through the appendix. They create an ulcer and then they lodge into the submucosa. From that, the submucosa, they evolve with inflammatory changes like the local edema, cellular infiltration, and characteristic caseating granuloma. Ultimately, they invade the lymphatic system, cause lymphangitis. When they enter the bloodstream, they cause endarteritis and fibrosis, leads to mucosal ulceration and stricture. So this is the more or less pathogenesis of abdominal tuberculosis. Characteristically, they traverse the mucosa and they leads to some ulceration. Now, I would just like to highlight a child, a 16-year-old boy who had weight loss and anorexia. The present weight is 40 kg, which is below 25th percentile. Height is 163, which is normal, 50 to 75th percentile. Mild pallor, BCG scar is present. There is no lymphadenopathy and systemic examination is normal. In February 2011, the child presented with pain abdomen and non-bilious vomiting, and it was a recurrent feature with waxing and waning. And when after about 4 or 5 months, the child came to the facility, the routine investigation showed hemoglobin of 9, platelet 1.7 lakhs, ESR 21. Serum albumin was 29, tuberculin sensitivity test was 24, and chest X-ray was normal. So this was the overall presentation. That means the child had abdominal symptoms suggestive of partial GI obstruction. The child had multiple mesenteric lymph nodes, which was detected in June by ultrasonography. Largest was 2 centimeter. There was abdominal pain and non-bilious vomiting, which suggests that it's a partial GI obstruction. Of course, there was loss of weight. And there was loss of weight and anorexia also over the last 4 or 5 months. And investigation, as we have already told, revealed this. So these are the striking features: weight loss, anorexia, along with that pain abdomen and non-bilious vomiting. So the CT scan of the child was done, the CT enteroclysis image. Now this is a hybrid technique in which the abdominal CT is done after infusing contrast into the small bile via NG tube. And the NG tube should go beyond the ligament of Treves in the duodenum to get the CT enteroclysis. And it has been shown to be superior to the other imaging tests like the conventional CT or even the barium enteroclysis. And here you can see it shows the thickened ileocecal valve in the terminal ileum and also caseating lymph nodes with rim enhancement. These are some suggestive features, radiological features of tuberculosis that we can consider in abdominal tuberculosis. Colonoscopy was done, which showed nodularity in terminal ileum. The ileocecal valve was normal and the biopsy was normal. USG guided lymph node FNAC was done. It showed epithelioid granuloma. Luckily, Zedenstein revealed acid fast bacilli, and also expert RIF MTB was detected. So the diagnosis was obvious. It's an abdominal tuberculosis, ileocecal tuberculosis with mesenteric lymphadenopathy. So due to this investigative procedure, the diagnosis could be reached effectively. Now, we all know, we have learned in the previous class that a lymph node biopsy is quite helpful if it's possible, like it was possible in this case. The fine needle aspiration, the cytology is very sensitive, and of course specific sensitivity is in the range of 80 to 100%. Specificity is also 90 to 100%, and the diagnostic accuracy, if it's taken properly, is 100%. AFB smear, the sensitivity is very low, but luckily in this case the smear was positive. The culture also, the positivity rate is 20 to 50%, and expert for MTB RIF, it's about 35% positive compared to 7% that we might get in smear. And of course, the USG guided tapping of the necrotic center can improve the yield. And here in CT, we could find the necrotic glands also. The other way is the excision biopsy with histopathology, smear, and culture. Though it's often not possible in abdominal tuberculosis, if possible, a lymph node study can aid in the diagnosis. So if we have an abdominal lymph node enlargement, if it's possible to take a biopsy, then the first step is a smear examination for AFB by Zn staining. Also, CVNAT should be done in all such cases for Mycobacterium tuberculosis from lymph node, and also MGIT culture, because this solid media culture has really opened a new avenue for diagnosis of tuberculosis. And then needle aspiration for CVNAT. Now, if the diagnosis is confirmed, if the aspirate from lymph node shows Zn stain positive for AFB, like this case, CVNAT, MTB positive, or caseation in granuloma. If these are present, then definitely we can treat it as a case. But if there is no granuloma, there is a non-caseating granuloma with no AFB, then we have to go to the next step, as I was showing in the previous slide. Consider excision biopsy. So consider lymph node biopsy to rule out an alternative diagnosis. Lymph node enlargement with TB skin test positivity, but without suggestive finding on needle aspiration for CVNAT or pathology, should not be treated with ATT. So this is the overall direction if we can get a lymph node from abdominal tuberculosis, because otherwise abdominal tuberculosis is often quite a perplexing situation. Now, this is a 9-year-old boy with fever, anorexia, weight loss, generalized abdominal distension with mild pain, pain abdomen, and partial relief after defecation persisting over the last 2 months. There is no history of jaundice, edema, loose stool, bloody stool, vomiting, and no contact with Cox also. There's no pallor on examination, icterus or clubbing, and on abdomen palpation, abdomen is soft with mild distension, no organomegaly, but ascites is present, and there is shifting dullness that can be made out by percussion. The other systems were normal. Investigations were done. Hemogram was hemoglobin 10.7. It was microcytic hypochromic anemia, platelet normal, total leukocyte 6,000, ESR raised 63, bilirubin normal, liver enzymes slightly raised, serum albumin 3.7, INR 1.2, chest X-ray normal, sputum for AFB was tried. It's a 9-year-old boy, but both the time it was negative. Then the ascitic fluid was tapped. You see here the protein is 5.4, glucose is 67, the total count is 500 with predominantly lymphocyte, 90%. Adenosine deaminase was 51, but it is many times done and given a lot of importance for diagnosis of tuberculosis, but ADA or adenosine deaminase is not at all recommended, and it's not at all a diagnostic marker for tuberculosis, because ADA is synthesized by leukocytes, and it can be elevated in many other infections, particularly bacterial infection. So ADA is not at all diagnosis of tuberculosis, and it is not recommended also uh, to to aid in the diagnosis of tuberculosis. Serum ascites albumin gradient was 0.9. Ascitic fluid AFB was negative. TB culture was awaited. So the overall impression from the protein of 5.4, glucose of 67, the total count with lymphocytic 90%, and the serum ascitic albumin gradient, which is 0.9. This is an exudative ascites. Now, exudative ascites is most commonly due to tuberculosis. Vis-a-vis the transudative ascites is more likely due to portal hypertension and obstructive features. One of the diagnostic feature of exudative ascites is the serum ascitic albumin gradient, that we detect by subtracting the ascitic fluid albumin from the serum albumin, and if it's less than 1.1, then it is exudative, and if it's more than 1.1, then it is transudative. Here it's 0.9, so this is exudative, and it suggests tuberculosis. Of course, as we discussed previously also in microbiology for tuberculosis, the ascitic fluid AFB and also CBNAT is not very helpful. Here you can see the fluids like pericardial or peritoneal, the sensitivity of GeneXpert RIF assay is about 50%, which is a very high confidence interval. So it is not very helpful, and we are not expecting also much. So here we have to rely much more on whether it's an exudative fluid to diagnose abdominal tuberculosis. Now, CT enterography was done, which showed moderate ascites, as we can see in the red dot here, with enhancement in visceral peritoneum. There are few internal septa which is seen in the CT. The omentum is thick, as we can see here. There is thick omentum. It was actually 13 millimeter. The large and small bile loops were normal. Multiple enlarged diameter. Other organs were normal. So the ascitic fluid study and also the CT points towards a probable tubercular ascites, and based on this fact, the child was started on anti-tuberculous therapy. Now, this is a 13-year-old girl presented with 1 year history of weight loss, off and on fever, recurrent anasarca, and features of chronic small bowel diarrhea. You see here on and off fever, small bowel diarrhea for about 1 year. On examination, the child was pale, markedly pale, with pedal edema. Anemia was there, platelet normal, albumin 1.8, albumin low, ESR high, liver enzymes normal. IgA, TTG was negative. Duodenal biopsy was normal. Chest X-ray normal. Tuberculin sensitive test done outside was positive, and USG was normal. Now, in this child, colonoscopy was done, and colonoscopy showed deep circular ulcer, pseudopolyp, and ileocecal valves distorted and ulcerated. So here the diagnosis is a confusion, whether it's a Crohn's disease or it's an intestinal tuberculosis. Now, as a matter of fact, intestinal tuberculosis very often is misdiagnosed with Crohn's, and the features, they often overlap. But if we analyze in detail, sometimes we might get some clue. The Crohn's disease usually has a longer duration, about a year. Whereas intestinal, Crohn's disease usually has a longer duration, more than a year, maybe 4 or 5 years. But intestinal TB usually has a shorter duration, maybe about 1 to 2 years. Chronic diarrhea is more often associated with Crohn's disease like the blood in stools, also more often associated with Crohn's disease, is much less common in intestinal tuberculosis. Perianal lesions and extraintestinal symptoms are more characteristic of Crohn's disease, may be present in 1/3 to half of the patients, but it is rare in intestinal tuberculosis. Fever is usually more often associated with intestinal tuberculosis, and partial intestinal obstruction is more common with intestinal tuberculosis than Crohn's disease, as also ascites than Crohn's disease. So these few features might help us to distinguish between Crohn's disease and intestinal tuberculosis, which often mislead us. Endoscopy is, of course, one of the diagnostic features. As we can see here, the TB causes transverse ulcers, while long ulcers are hallmark of Crohn's disease. Well, I am not an expert in endoscopy, so I cannot describe much. This is what it's written. The transverse ulcer, you can see the pictures of intestinal tuberculosis here, and these are the Crohn's disease, where the ulcers are long, the serpiginous, and also presence of aphthous ulcer. So the dilemma continues, whether it's intestinal TB or Crohn's disease. A biopsy definitely can be taken. The colonic biopsy, presence of caseating granuloma, and if AFB is detected, points towards intestinal tuberculosis and justifies initiation of anti-tubercular therapy, 6 months, 2 HRZD, 4 HR. And in this child also, symptoms resolved, and follow-up colonoscopy showed improvement. Child also was gaining in weight and height. So in current times, the colonoscopy biopsy should be subjected to CBNAT. As always, we must rely on microbiological diagnosis. So the imaging options for intestinal tuberculosis, what we have is that plain X-ray is usually not diagnostic. Sometimes it might show enteroliths, perforation, or features of intestinal obstruction which are not at all specific. Ultrasonography of abdomen might detect lymphadenopathy, peritoneal thickening, omental thickening, and bile wall thickening, and of course ascites. And if lymphadenopathy is present, and if the caseating center can be detected, it is definitely a marker for abdominal tuberculosis. Now, the appearance of affected lymph nodes in abdomen on tuberculosis may vary from normal size to enlargement also. And of course, the most common presentations are multiple mildly enlarged node in clusters usually. And if they have central caseation, necrosis, then with peripheral enhancement, then this is definitely an indicative. And lymph nodes over 2 centimeter in short axis diameter makes them significant for tuberculosis. And smaller nodes can be seen in many patients due to non-specific enteritis, and there we should be careful to diagnose tuberculosis. Now, the ultrasonography is, I have told already, contrast CT that we have discussed previously, and of course the barium study. These are the imaging options. And the CT enterography, the ileocecal area is the commonest area affected. Uniform and concentric bile thickening, contracted, pulled up cecum, ileocecal angle is distorted and often obtuse, and short strictures, usually less than 3 centimeter. And USG or CECT, as we have been discussing, abdominal lymph nodes, the caked omentum, multiple space occupying lesion in liver or spleen may be present, and also loculated pleural fluid may be present. So recurrent or chronic abdominal pain and mesenteric lymphadenopathy, if we get the recurrent or chronic abdominal pain itself without constant symptoms, is a common problem in children and has diverse etiological causes that we all know. chronic constipation is one of the frequent cause we might get, and up to celiac disease, this might present with recurrent abdominal pain. USG finding of mesenteric lymph node enlargement that we have already discussed, and associated with GI tract or upper respiratory tract infection by a number of different viral, bacterial, parasitic organisms other than Mycobacterium. And also 17 to 65% children with recurrent abdominal pain can have non-specific mesenteric lymphadenopathy, often a reactive lymphadenopathy that usually doesn't require any ATT at all. Often demonstrate this chronic abdominal or recurrent abdominal pain often demonstrates a poor relationship between symptom relief and resolution of lymphadenopathy. So recurrent abdominal pain without any red flag signs with isolated mesenteric lymphadenopathy and normal abdominal examination is highly unlikely presentation of tuberculosis. So recurrent abdominal pain alone or chronic abdominal pain, we should look for other causes. Now, significant abdominal pain, that is Apley criterion. Now, the Apley criterion is the syndrome of recurrent abdominal pain in children as 3 episodes of abdominal pain occurring in the space of 3 months, severe enough to affect daily activity. This is the Apley criteria. 3 episodes of recurrent abdominal pain, episodes occurring in a space of 3 months, severe enough to affect daily activities. This may suggest tuberculosis if it's associated with abdominal lymph nodes, with central necrosis, conglomerate nodes, peripheral enhancement, cake tomentum, multiple SOL, loculated ascites, mesenteric thickening, and specifically increased with presence of abnormalities other than isolated lymphadenopathy. So these all should alert us about a possibility of abdominal tuberculosis. Abdomen is a very confusing area, so we have to be vigilant, but we must exclude the other causes also. The common errors for diagnosing of abdominal tuberculosis are insufficient evidence for starting of ATT. Like mild grade of fever is not always fever, TB. USG abdomen showing subcentimetric lymph nodes, that is lymph nodes which is less than 1.5 or 2 centimeter. Failure to gain weight is often subjective if not documented, and often is due to various other causes. Functional abdominal pain is another possibility that we as pediatricians deal so frequently, and chronic diarrhea without proper evaluation. Well, Crohn's disease should be at the back of our mind. So around 18% of children with functional abdominal pain in some studies actually received ATT which were unnecessary. And also, in chronic diarrhea, about 19% of celiac disease patients received erroneous ATT. So we have to be vigilant, and these are some of the situations where the children are prescribed ATT when it's not indicated and after incomplete evaluation. So abdominal TB diagnosis, the challenge is that non-specific variable symptoms, low yield of Mycobacterium on smear and culture as it is common with pediatric tuberculosis. Multimodality of investigation should be the motto. USG, CECT, enterography, colon biopsy, if required laparoscopy. Now, positive diagnosis should be always attempted to avoid irrational ATT, and abdominal TB should be differentiated from Crohn's disease, lymphoma, and other causes of ascites, because wrong diagnosis is harmful. Correct diagnosis, if missed, then that leads to grave eventuality, and inappropriate therapy may cause MD or tuberculosis. And of course, all the ATT drugs do have their side effects that we will discuss in our subsequent sessions, and hepatotoxicity is a problem. So with this outline of abdominal tuberculosis, let us move to another often a confusing area and often a difficult area in pediatric tuberculosis, is the bone and joint tuberculosis. Now, Bone and joint roughly accounts for about 5 to 15% of all extrapulmonary tuberculosis, about 2 to 5% of all tuberculosis in children. The common presentations among these are, one is Pott spine, which is about 50% of all cases of osteoarticular tuberculosis. Then dactylitis, arthritis with extension from the metaphysis of hip and knee joints, osteomyelitis. Uncommon presentations are reactive arthritis, tenosynovitis, and bursitis. Now, each of the most frequently involved bones and joints has a characteristic incubation period that we must remember. One is the dactylitis, which usually has a very short incubation period, about a month, whereas the tuberculosis of the hip might have an incubation period of 2.5 years also. The characteristic of skeletal tuberculosis in children is that in young children, the blood flow usually through the growing bones is very intense. Now, due to this, they suffer from skeletal tuberculosis more often than older children because their blood flow in younger children is more. And the lesion usually starts from an area of endarteritis in the metaphysis of long bone, where the blood supply is particularly abundant. Like we were telling, the arthritis extension from metaphysis of hip and knee, and also sometimes dactylitis. The bone infection can be initiated again by two other mechanisms other than this blood supply, enhanced blood supply, and the endarteritis and affection of the endarteritis in the metaphysis of the long bone. One is direct extension through the lymphatics from a caseous paravertebral lymph node, and also local hematogenous or lymphatic extension from a neighboring bone. So these are the various mechanisms, and these are the common sites. Now, dactylitis, the tubercular osteitis, the dactylitis form often affects children. It may be multiple and also the consecutive bones may be involved. Clinically, it presents in the short tubular bones of the hand and feet in children, typically the proximal phalanx of the index and middle fingers, or the index and middle, or the middle and ring finger. Metacarpals often follows a benign course without pyrexia and acute inflammatory sign. So this is an ominous, and sometimes it follows a trivial trauma also, whether the trauma aggravates the condition or the condition precipitates trauma. That is sometimes very difficult to say, but often it's associated with a trivial trauma. And the X-ray features, the involved bones show a diaphyseal expansile lesion. A periosteal reaction is common, and they usually heal by sclerosis. So this is a 17-year-old female, low-grade fever with evening rise for about 4 weeks and pain in the upper back for 2 weeks. Progressive increase in weakness of lower limbs for 2 weeks. Right intrascapular region swelling of about 6 centimeter by 5 centimeter, which is non-tender, firm and not fluctuant. The power in lower limb is decreased 3/5 with exaggerated reflexes and upgoing planters. Now, what are the possibilities and how to investigate this? Now, this was the X-ray feature of the chest, as I was telling, the right intrascapular region swelling of 6 centimeter into 5 centimeter. Here you can see the swelling, and the MRI spine revealed this, the Pott spine with paravertebral abscess. Now, usually the thoracic vertebra is involved in the Pott spine, and most commonly the 12th vertebra. Here you can see a huge collection. Now, initially there in the MRI, there might be slight narrowing of the disc space with only minimal disc space narrowing and slight collapse also. But as it progresses, the angulation of the spine is marked, which is externally observed as gibbous, and extensive destruction of the bodies with severe kyphosis results in the classical Pott's disease that we describe. So it's a destruction of the intravertebral disc initially as progression from the collection, and also subsequently erosion of the adjacent vertebral body that produces the angulation of the vertebra, and that causes the gibbous formation. So the clinical features of Pott spine: insidious onset of back pain, most common site thoracic, lumbar follows, cervical is rare. Pain may be localized over the involved vertebra or could be referred due to root pain. There is local tenderness or deformity, and unfortunately, fever and constitutional symptom is only present in 1/3 of patients. So that might delay our diagnosis, as the gibbous and the spinal deformity takes some time to develop by the time the disease has progressed to some extent. Neurological complications may be paraparesis, Cauda-Equina syndrome. About 15% patients, they have paradoxical response with increased neurologic deficit following therapy also. So that's also another feature of Pott spine, and risk of kyphosis in later life, especially if it occurs in children below 7 to 10 years. Imaging finding, X-ray finding is abnormal only in about 1/3 to half of the patients. Bone loss may be observed. It may also show plate erosion, decrease in height of vertebra, collapse, and narrowing of discal space and paravertebral soft tissue shadow. But these are the features when the disease has progressed somewhat. Other than that, there may be a soft tissue shadow also in the perivertebral region. Now, MRI is most sensitive, nearly 100%. It will show marrow edema, destruction of adjacent vertebral bodies and opposing end plates, destruction of intervertebral disc also, and occurrence of prevertebral, paravertebral, and epidural abscess. And MRI will be helpful in diagnosis skeletal involvement earlier than X-ray because it is more sensitive. The important point of treatment of Pott spine is that here the therapy is 2 months of HRZD and 10 months of HRE. The continuation phase is prolonged by 6 months. There are some reports, some data which shows that even the 6 months therapy is perhaps as effective as longer treatment. But considering the gravity of the situation and the possibility of long-term sequelae of spinal deformity and neurological signs, it's probably prudent to treat spinal TB with 12 months therapy. Sometimes the surgical intervention is needed, definitely, for those with progressive neurological deficit, or if there is persistent pain, spinal instability, high risk of future kyphosis, as I have told already, in children less than 7 to 10 years, 2 or more vertebral body collapse, and existing kyphosis of 30 degrees. So in such cases, an early surgical intervention is needed to have a better long-term prognosis. Thank you. Thank you so much. There is one question, why ADA is not recommended. Well, I have already discussed that ADA is secreted by leukocytes, adenosine deaminase, so it can be elevated in all conditions where there is increased leukocyte, and maybe elevated in other bacterial infection also. So it should not be relied much for diagnosis of tuberculosis. I mean, it should not be done at all. There is no role of ADA for diagnosis of tuberculosis. Any message from Dr. Kundu you want to pass on?
What I was telling regarding ADA, actually ADA is an enzyme which is produced by nucleated either activated lymphocytes or neutrophils. So both, what we want to distinguish whether it is a pyogenic or tuberculous. In pyogenic, neutrophils liberate ADA, and in tuberculosis, it's the activated lymphocyte liberates ADA. So you cannot distinguish between these two. This ADA has been done with an idea to distinguish in malignancy. In malignancy, there is a huge number of cells. So in those cases, the ADA is very high. And moreover, none of the studies of ADA has done in children, mainly in adults. So ultimately, ADA does not serve any purpose in diagnosing tuberculosis, especially separating it from pyogenic infection. So that's the reason why it has not been taken up.
One question is about diagnosing TB peritonitis. Well, as we have discussed that the peritoneal fluid study might not yield much. So for peritoneal TB diagnosis, sometimes if required, we can go for peritoneal biopsy also. There, if we can detect granulomas, caseating granulomas or AFB also, so that will be diagnostic.
Ascitic variety of peritoneal TB will always have exudative. The protein should be in the fluid more than 3.5 or even more.
These are always helpful, but ultimately, if
ultimately you
can
cannot. Ultimately, you have to do a peritoneal biopsy, and you have to take a laparoscopy. Also, you can do. You can select.
Okay, thank you then.